Hi everybody, Clarke Tanner, physical therapist, life coach, and founder of Thrive Physical Therapy in Richmond, Virginia. And this is your weekly podcast, Strive to Thrive, designed to help improve your health, increase your success level, and thrive in life.
Yeah, my name is Cody. I'm a physical therapist here at Thrive Physical Therapy. And today we thought we'd bring to you guys the topic of what are the three most problematic mobility impairments, or the areas for that we tend to see. And this kind of stemmed from our idea of like, how can we help people identify some of the areas that they maybe have concerns with before they even have pain. Now, you may be experiencing issues or you're experiencing discomfort, but before that, even you may be having stiffness or issues with mobility in these areas. We wanted to make sure that people kind of understood where those areas are that we see a lot of times that are affected, and then also why they're so important to maintain mobility in those segments before you even start to feel an adverse effect from it.
Yeah, so ideally preventative in nature, so you do never develop a problem or pain. But also the other side of that, these are three major areas that even for a mix of good, I mean, we treat people with back pain, that's one of our specialties, but we deal with hip pain, knee pain. There's all kinds of different things that we help people with. And there's things that we sort of universally see that really needs to be addressed in a major way to really have a good outcome and have people feel good. So
what's number one area for you right off the bat?
Okay, so I'm going to get two, and then so it's hip mobility and ankle mobility, or said better, lack thereof, or both.
There you go. That's important.
And I got a great story for you for directly with around a patient client that I'll give you in a minute. So.
Okay, cool. Yeah, and then my area topic that we'll probably discuss would be more thoracic mobility, right? And we'll kind of get back into that a little bit more, but thoracic spine just refers to mid-back, right? So area between your neck and your low back. It's quite a large span when it comes to surface area of your back, but basically it tends to be the position where people tend to start rounded at their upper back. It's usually a postural impairment, and it can sometimes affect how people move from a whole substance of areas.
So this, not being able to do this, or not being able to rotate, would be that part. And then ankle, particularly that hinge, that's ankle, that's dorsiflexion, that's plantar flexion. Usually the more problem is here, okay? Pardon the example. And then, so along those lines, hip flexion and hip extension, okay? So real quick, pardon the examples, but
we gotta use the video camera when we can. That's the reason why it's a video call.
Give you a real easy example, okay? If you don't have hip extension, then that causes you to not be able to have enough extension. You have to have hip extension to take a step, okay? If you don't have that, then what tends to happen is we cheat with lumbar spine. So in other words, as the leg goes behind, the lumbar spine moves. Well, that's not your lumbar spine is not necessarily designed to every time you take a step when you go into hip extension to go into the lumbar spine to compensate and be the place that we cheat. So anyway, that's to help orient.
Yeah. Very good. So let's go ahead and let's hear that story about your ankle and your hip person. Dealing with some issues.
This was a good experience. Well, I learned a lot from it. Let's just say it that way. I would say it wouldn't be a good experience. This happened early on in my career, and it was nice to. I'm appreciative to have learned this. Okay, so an easy example. Okay, had a patient that I worked with that had a lumbar surgery. Prior to seeing me, he had a lumbar surgery and had a discectomy, right? Well, got a hold of him. We started working with him, and he had also had this prior history of a problem with an issue in the ankle where he had an ankle surgery, a bone that started to sort of break down, and they had a surgery. They managed to kind of save it, which was good. But long story short, he didn't have a whole lot of ankle dorsiflexion, okay, which was the motion I just showed you. Okay, so anyway, we worked with him. We tried to work on the ankle a little bit. We worked on getting everything we do in physical therapy, gaining trunk mobility and strength and all these things. He was really doing really well. We tried to change the ankle. That improved some, but he looked great. Well, anyway, he graduates, and about a year later, I talked to him, and he comes back in, and he actually re-injured his back and actually herniated the disc, okay, sort of a second time. And we had a conversation around it. I said, well, what were you doing? And he showed me how he was just squatting down to pick. I think he was doing laundry. It wasn't, I don't remember the specifics of what it was, but some very common thing. He squatted down And right at the point where he'd squat, when you squat, you have to be able to have ankle motion because that's what enables you to use your hips. Well, right when he got to the end position of his hip, his ankle motion, his lumbar spine would flex. So you could literally see it. So it literally took like 10 seconds to go, okay, well, you could see why with the ankle mobility deficit that he had, his lumbar spine would flex. He'd compensate from his lumbar spine. So it was really easy to see why if he's picking something up, it's going to create stress on his back. So kind of a wake-up call. It's like we had tried to change that ankle, but it was his ankle problem that everything else had changed. That was the one deficit that still needed to be improved. Well, so fast forward, we worked really hard on that ankle, and we got his motion back. Well, then after that, he was able to squat, and he could keep his spine in a nice position, and he could actually use his legs when he would lift. Never had a problem again. So great example early on in my career as a fairly young therapist is so many things are above and below can make a big influence on how well you move and whether or not that will feed into a lumbar issue. So being able to use your hips and use your legs, massively important for a functional task like that. So learn that lesson very early.
As a young therapist, I think, and this is something that I'm learning, and I'm still getting better at, obviously developing over time, but I feel like I've got being here and working in a clinic that does a lot of a full body or a systems approach to see, look at mobility deficits. I think you get tunnel vision when you're young because you see the problem area, right? I have pain in my back, is probably your back, right? And that's where you focus, and you know all these information and the back tests and the stats on it and all these things. And so it's easy to get engrossed into that area, and it's harder and harder to tunnel out as you start to do that. Luckily, we use a system of screens, a system of motor analysis that helps us define that early on, which I think makes us pretty efficient at what we do. But at the same time, I can see as an early therapist, and something I had to battle with early on was how do I bring my scope out to these other problems, these other systems that play a role. And you can definitely argue the same for hips. I think ankle mobility can play. You can see how someone's ankle dorsiflexion can really impact how they flex up their back when they lift something. You can say the same exact thing for someone's hip motion. If you lack the flexion of your hips, which is hips coming up, necessary, then you're going to have to compensate by rounding at your back. And if you're picking something heavy up, it just puts more load into your lumbar spine, and that's where most disc herniations occur. So I think finding out that, you're more prone to injury if you lack ankle mobility or hip mobility in your lumbar spine. I would say even more so than you are limited in an ankle injury or a hip injury. Those segments are too stiff, so the chances that you're going to get an injury are actually less, I would say, because you lack the mobility necessary to apply a lot of force to those areas.
Yeah, it won't be that gets hurt. It's the thing above and below it. It's the compensation point, which is the point we're trying to make.
Yeah, exactly. It's like if you put if you say you have a pipe that's leaking and you put two really sturdy or good patches on it, it's the middle section that has a chance of blowing out now because the pressure is not changed, right? It's kind of the same thing with ankle and hip when it comes to the spine or when it comes to any kind of other injuries.
So can I ask you a question along these lines? Okay, so so in a situation like that, when someone lacks hip mobility or ankle mobility, like the example we just how effective is trunk stability? And does trunk stability make a difference? And if we're doing lots and lots of core training, what's still going to be the effect?
There you go. So I think that's what's going to kind of get to is trunk stability is great. I think everyone can benefit from trunk control. I mean, I think as a physical therapist, I can throw trunk control into literally any training program, and you're going to receive some benefit just because it's the center of your body, it's where everything else originates from. We use the term proximal stability, proximal meaning close to your midline, leads to better mobility, and distally meaning away from your midline. So if your trunk's better, then your arms, your shoulders, your hips, your ankles tend to move better. However, if I'm focusing on someone's trunk, let's say they have back pain, or trying to do a lot of trunk control stuff, and their mobility deficits at their hips and ankles, I'm not going to get a lot of success. Whether their trunk has to overcompensate for lack of mobility in their ankles and hips. And so they're not going to be very successful at their training. Or two, you're going to have this underlying deficit that the trunk control might mask for a bit, but in time, as either the trunk control training starts to fade off or the mobility deficits get worse in the hips and ankles, they're going to start backsliding. And I think you're going to see changes at a deeper level in that regard. So
very well said. Right. So if you don't have mobility somewhere else, you're going to give up stability to accomplish your movement. And trunk stability would be helpful, But if you have a mobility problem somewhere else, well, you have to address that first.
It's a shallow fix. It's like I'm making it look better, but I'm not making it better. And that sometimes is good. I'm not saying that's not bad. It's better than the alternative, which is nothing improves. But I think at the same time, you're not getting to the root of the cause, and it's like putting a nice paint job on, an old rusty beat up car.
Right.
There's still issues underneath all that, even though it looks nice.
And so what would you say are some of the real keys to success long term? Like in terms of getting rid of a back issue, knee issue, whatever, what are those key elements? We're talking around it.
Right. Well, I mean,
For sure.
it's mobility, right? That's your groundwork, I would say, initially is tone and tension, right? If I'm going to start anywhere, I want muscles to be relaxed. I want you to be able to accept mobility well, right? So the first thing you got to do is make sure someone can relax in the movements. Because if you're tense and you're rigid during mobility, I wouldn't really say you're doing a very good job. Right?
No,
so
you're not.
You have to be relaxed. Secondary to that, then you got to make sure that you have good range of motion and that you can move well into your in-range positions. And in-range just refers to how far your joints can go, basically. And once you have great mobility, then it's control, right? So it's kind of this pyramid where I have to be able to accept movement, then I have to be able to move well, and then I have to be able to control that movement well, so I'm not going to give up any kind of things besides that. I'm not giving up mobility for functional quality.
And is there a difference between, and you just alluded to this, but to me this is always fascinating because we see it so much in the office, is can someone look like they have mobility, but then when you test them with stress or load or in an actual movement task, then they don't have it? So
I would say that's the difference between range of motion and functional mobility. You see that term used a lot. So you might have someone who comes in with fantastic range, so passively, or meaning if I'm moving their joints, or if there's very low load and they're moving very gently, they may go very far in their range of motions and make sure all this, I'm so bendy, I'm so flexible, right? But then you put a coordinated effort into it. So you give someone a coordinated task, like with multiple moving segments, or if you give someone load, right? So you put some weight in their hands, all of a sudden that mobility goes out the window. That just tells me that you're lacking strength and control potentially versus true range of motion.
Right.
That's why we use functional testing a lot of time to determine if someone needs true stretching or mobility versus someone needs control. If I look at it on the table, it might look fantastic, right? So I would say I don't need to address this, right? I put that person in a deep squat and make them hold, may have them hold some weight. Oh my gosh, the hip mobility falls out, their back starts to bend, everything changes. I would say functionally that person doesn't have mobility anymore. Right. And so they have to either, if that matters to them, they have to increase their control, their demand, or to hold those positions. Because ultimately, we don't do a lot of things without load. Really we don't. We're typically, in some way, when we need mobility most is when we have load on our body. And that's when you have to be able to use it.
Right. Very, very well said.
Yeah.
And from in terms of some little bits of take-home messages, many times issues, someone comes in with back pain, or maybe an easier way to articulate it would be somebody comes in with knee pain. It's something happening above, like a mobility issue or a control issue or whatever, that's resulting in the stress of the tissues, giving someone knee pain. And if you address those, figure out the why, figure out what's happening, take a little bit of a more global look at things, address those issues, and you make the knee pain, the tissues in the knee heal and the knee pain go away without potentially never having even touched it. And it's around some of these principles that we're talking about. And that's kind of the key to really being very successful. And doing a good job of keeping things. The goal is to get something to get better, right, and then not have a problem later. And then from a preventative standpoint,
do it now. Prevent yourself from having issues later. And I think that's the point. It's like you have to be able to recognize or just understand that good practice, good mobility practice, it requires frequency and consistency. If you don't have either of those two things, then you're going to develop over time issues with mobility. And how impactful those are depends on your anatomy and then what you do for a living and what your daily chores look like and everything. But you just have to know that if there's a deficit, it does lead to issues over time, especially, and it just happens faster the more load you put on your body, the more wear you put on your body over time. So let's talk thoracic spine. Let's go into that. Right, okay, so I don't want to completely forget that segment. So what issues do you typically see comes around when someone has a deficit in their thoracic spine mobility?
Oh my gosh, that's a huge one too. So here's another big one, right? So if you don't have this, which is the extension, well, you get the same concept. The example I gave you earlier about the lumbar spine extending because of a lack of hip motion or flexing because of the lack of hip flexion. What happens there is if you don't have the extension in the thoracic spine and rib cage, well, then you have to make up for it in your lumbar spine, and you'll extend your spine to be able to achieve an upright position. And that is a mechanically stressful position for the back. Plus, the other thing is our thoracic spine is very designed for rotation. And anatomically, it doesn't love tons of rotation. It should really happen from our rib cage. You don't have that, well, you're going to compensate again from lumbar spine. And so that's another one that's like massively important.
Yeah, I mean, I completely agree. And I think they're combined, right? So we talk about this combination of movements a lot of times. So our thoracic spine especially doesn't move very well if I'm particularly flexed or particularly extended. So if I'm a combination of movements, my total composition of movements less, which just basically means that if I'm flexed, let's say I don't have the ability to extend my spine and I can't get upright, well, then all of a sudden my rotation deficit's 30% less both directions because I've already taken up some joint slack, right? So one way you can gain 20 degrees of rotation is just by being able to be upright. Right? Some people have a very difficult time doing. That position, when you see this flexed upper spine, is usually called kyphosis. Kyphosis is normal in the thoracic spine. We expect some level of flexion.
Some
level of flexion. But it shouldn't really be apparent when you're walking around or thing. You should be able to maintain upright. If it's flexed and I can't reverse it, that's when we get concerned about mobility especially. So, but going back to the rotary aspect of thoracic spine, which I think is super important, when it comes to exercise and how your thoracic spine limitation may affect you, whether it be extension or rotation, what are some exercises that get compromised pretty quickly when you don't have a great thoracic rotation motion or great thoracic motion in general?
You mean like what activities?
Activities, exercises, anything.
Gotcha.
Just what do you do? Like, how do I know that I might have a thoracic spine deficit?
Okay, well, so a few things. First off, if you look at sports that really require anything that requires rotation is where things show up, right? That would be like tennis, golf. Those are a couple of areas where it becomes kind of readily apparent. And then in terms of maybe having a thoracic spine, that one's not always super easy to know, but if you don't have thoracic motion, many times symptoms can start to occur in the neck or the lumbar spine. So things start to become uncomfortable, particularly after activities like we just described, something that requires rotation. So you might become uncomfortable after that. Or it might just, in a situation where something doesn't hurt, it might just be sort of a more difficult position to achieve or feel harder to do.
Yeah. And my big one's usually overhead motion, right? So I see this, this is like I see this all the time, right? People are like, oh, my shoulders are very stiff, and the arms overhead, and I can only get, 80% of what I should be able to achieve, right? So if you lift the thoracic spine, all of a sudden the person gains 20 degrees of shoulder motion. It's not a shoulder issue, right? Your thoracic spine's limited. So I get people who come in doing a lot of military press and lat pull downs and, overhead presses. And it's like, I keep getting shoulder pain. Well, it's like, your shoulder's not the problem. A lot of times it's your thoracic spine that's limited. You don't have the control necessary to maintain upright posture while you do these exercises. And that completely changes the architecture or the functional mobility of your shoulder joint. So I see people who have typically issues. The shoulder joint's so mobile from an anatomical standpoint that it's rare to see a true shoulder deficit mobility, I would say. It's designed for mobility. It's actually designed to be such a multidirectional, complete ball and socket joint that a lot of the times the deficit comes from another part of the body. It could be the scapula, shoulder blade, it could be the rib cage, thoracic spine, yada, yada. But thoracic spine tends to be the most common, I would say, in conjunction with how people feel. And then that mobility issue resonates into, scapular plane, shoulder blade, and then rib cage.
And the other just example to throw out there too is like, things up here that create arm and hand symptoms. That usually is the neck. Many times secondary to a problem with thoracic spine. So it's just, again, it's all in where you sort of compensate and where the problem is, and the key is just kind of figuring that piece out.
Yeah, and I think the big takeaway from today is that we know that it's that whole proximal mobility deficit, right? So it's like that whole, if I have problems moving from the base of my body, thoracic spine, hips, and ankles, right, everything that's close to midline. I tend to have issues moving around a lot of portions of my body, right? These are, you really, if you look at thoracic spine, hips, and ankles, those are your big, swaying fulcrums, right?
Yeah.
Those are where most of our motion comes from. Your knees would be considered another quite a big fulcrum, but with good form, I would say the compressive loads through your knee joints would be pretty minimal. You should be able to constrain forces through there and primarily put it in your hips, which are a much larger, more capable joint with more directional stability.
Yeah.
So if I'm trying to load a joint that's appropriate for handling heavy loads and big extremes of motion, it's your hips, not your knees, right?
Yeah.
Your knees are just single hinge with a little bit of rotation. They're not designed in a way that's supposed to take a lot of compressive load. Your hips are those, and ankles should be the kind of the piece that controls all that motion from the ground up. And so I think we just know that if you can start with those three areas for good practice, then you're probably going to have a pretty good result going, above and below the chain for all moving segments otherwise.
Yeah, very well said.
Yeah.
So just major take-home message for you, and then I'll
Feel free. Yeah.
Yeah.
So the biggest thing I would say take home is if you're going to, first of all, address these impairments before they're a problem, right? So consistency and frequency is the number one thing that really matters when it comes to mobility. It's not about pushing to your end ranges to the extreme. It's not about getting into yoga positions for a minute or 2 minutes and holding a long sustained stretch. That stuff can be helpful. I'm not discrediting some of that. I'm just saying that if you're looking at the two factors that matter most is that you get enough of it throughout your week and you do it basically with your frequency, and then you keep it up for weeks and weeks on end, months preferably, and then eventually you build a habit toward a lifetime. And that's what really addresses mobility deficits and those key areas that we're concerned about.
Yeah, and then the couple of small take-homes that I would just encourage would be, one, being aware of how easy it is to move. Like if you feel like you're generally stiff or just things that you need to do on a daily basis just feels sort of, maybe it doesn't necessarily hurt, but it just feels difficult. A lot of times it's around some of these mobility issues that might be an underlying issue. If something hurts and is painful, well then I would encourage, please consider getting a bigger, more broad look at what maybe is contributing to it. Because many times why that particular body part will hurt has a lot to do with other things happening, in different areas, and it's potentially compensation. Or you need to figure out what the particular puzzle pieces are that need to be put together, and to get guidance by someone who physical. Certainly, this is what we do, and we like figuring this sort of thing out, figuring out the puzzle piece. So I would say, if you're in our area, absolutely give us a chance to help, or at the very least, get to somebody who can give you some good professional guidance around figuring out what your particular deficits are and then help you to get rid of it for long term.
Yeah, I mean, my recommendation to most people is see a physical therapist once a year. Honestly, and this is something we could probably have a whole other podcast about, which we might get into at some point in the future. But you usually get a yearly or an annual checkup with your PCP. You usually get an annual checkup with your cardiologist. You get all these checkups. There's nothing wrong with having someone do a physical assessment of how you're moving and how you're doing, and then giving you, just like a PCP would, advice on how to manage whatever medical symptoms you're dealing with. Treat your physical body just as you would your internal structures, to make sure that you're doing well. And a physical therapy assessment can sometimes be a great start. It's a great value. You can get some good advice, and then you can maybe see some areas where you need to put some work in to give your exercise routine or whatever you're doing a little bit more structure, a little bit more guidance.
Yeah. Prevention would be the key, right? You'd never consider going a long time without taking care of your teeth or not going to the dentist. We feel the same way about musculoskeletal stuff, and try to get people to be proactive. It's way better to be proactive. It's like the whole saying.
Half the time, half the effort, associated with it. So, see a PT. If you're in the Richmond area, please come see us. We'd love to help you out. If you're not in the Richmond area, find a physical therapist that you trust, talk to your doctors, and find people that you enjoy working with, and then really kind of drill down some of this stuff, and then help your body feel a lot better for it as a result. So that's our.
No, go.
No, you're good. All right, so Vasquez, we're going to send us out on that note. So that should be our Strive to Thrive podcast on today's topic, which is focused around mobility deficits that we see often, and then major areas of impairment that we're hoping people will kind of address in their daily lives. And if you're looking for more information on how to do that, you can visit our website and then contact us as well, especially if you're in the Richmond area. We'd love to see you for a consult or an assessment. But please feel free to leave some comments below this link about some areas or some exercises that you've done to help you address some of these impairments, whether that be local exercise classes or any online material that you feel like was particularly helpful. Nothing wrong with spreading the word and getting people the help that they could use to get started. So we really appreciate that, you guys. But otherwise, this will be your Strive to Thrive podcast.
Yeah.
And we'll be signing off and hopefully give you guys some more content coming up the next 2 weeks.
Yeah. Thanks for listening, guys, and keep on thriving.
Thank you.